Good morning, respected Director Ma'am. Good morning to all the respected faculty, my seniors and my dear colleagues. Today, the Department of Medicine will be presenting the clinical grand rounds. The first case for the today, and the patient was a 38-year-old male resident of Muradabad, Uttar Pradesh and a shopkeeper by occupation. He presented to the emergency department of our institute with the complaints of dry cough over the past 15 days, progressive dyspnea over the past 10 days, and an undocumented fever over the past 5 days. The imaging was done in the emergency department itself. For the discussion of the imaging, I would like to call my radiology colleague.
Good morning, everyone. So this was the imaging that was performed in the emergency for the patient. On this first, second and third image, which are the lung windows of the HRCT chest, we can see that there are confluent areas of consolidation which are asymmetrical, predominantly in the peribronchovascular distribution and also in the bilateral lower lobes reaching up to the bilateral pleuras. There was also diffuse surrounding ground glass attenuation and few areas of bronchiolectasis as well as bronchiectasis in the bilateral lower zones. In the first image, we can see that there are some enlarged paratracheal group of lymph nodes, and also the consolidation is reaching up to the pleura, and there is no subpleural sparing. So on the basis of the clinical features as well as the present ongoing COVID pandemic, the first differential that we gave was COVID-19 pneumonia, CORADS 4, and the CTSI score was 13 out of 25. The second differential on the basis of these imaging findings, that is the peribronchovascular distribution of consolidation, bilateral patchy confluent consolidations. Second differential was interstitial lung disease, likely the cryptogenic organizing pneumonia pattern and NSIP. This is the reference image in which there is classic subpleural sparing in the NSIP pattern. Thank you.
So with that presentation in the emergency department and with the initial imaging, we kept our differentials as follows. The first differential was kept as SARS-CoV-19, keeping in mind that the time was of the third wave of the COVID-19, along with the history of fever and cough and the HRCT findings that were suggestive of the same. The other differentials were an atypical bacterial and viral pneumonia, which could have presented as a similar picture. And the other differentials that were still kept to be ruled out were heart failure, interstitial lung disease, and tuberculosis. So the patient was admitted in the medicine ward and a review of history was taken, and it was found out that the cough was in fact a chronic dry cough, which was initially non-progressive in the first 7 to 8 years, but then had progressed over the past 2 years, which had made the patient come in medical contact. He also had dyspnea, which was of chronic, insidious, exertional and progressive nature, which had progressed from MRC grade 1 to MRC grade 3 over the first 3 years and finally was MRC grade 4 at the time of presentation. He had undocumented fever over the past 5 days, and throughout his clinical course he had an associated on and off joint pain, but which was of non-inflammatory in character. In the past history, he was diagnosed as hypothyroidism 1 year back and was continued on medications, but there was no history of any comorbid illness like diabetes, hypertension, no contact with tuberculosis or past history of tuberculosis, no contact with pets, occupational exposure of smoke or dust, or any increased exposure to bird droppings, or any similar illness or history of TB in the family. This is the summary of his entire course, in which we can see that the patient had dry cough and dyspnea, which was of very progressive and chronic nature. In fact, the point of first medical contact was in April 2020, wherein he was diagnosed as having COVID-19 illness radiologically, was kept on oxygen requirement for 10 days and then discharged. Second contact was in June 2021, wherein he had again a similar presentation with worsened dyspnea, was clinically diagnosed as COVID without any oxygen requirement this time, also diagnosed as hypothyroidism at this occasion. And finally, presentation to us in June 2022 with worsened dyspnea. At the time of presentation, he was febrile, He was having tachycardia, tachypnea, and required 4 liters per minute oxygen on nasal prongs to maintain oxygen saturation at 98%. On general physical examination, some mild fissuring was noticed in the bilateral feet, and on respiratory system examination, the trachea was midline with reduced bilateral chest expansion, and on auscultation, there were bilateral basilar and inspiratory fine crepitations with the presence of right axillary bronchial breathing. So keeping it all on one perspective, he was a 38-year-old male with chronic dry cough, chronic dyspnea, and a short-lasting fever causing worsening of these two symptoms. A CT imaging suggestive of some consolidations, some patchy ground glass opacity, some perihilar opacities with bronchiectatic changes, and serology which was indicative of only raised inflammatory markers and otherwise within normal limits. So we revised our differential diagnosis at this point, and the interstitial lung disease was kept as the first differential, keeping in mind chronic cough, chronic dyspnea, inspiratory fine crepitations on examination, and the HRCT finding that was suggestive of an NSIP plus organizing pneumonia type of pattern. The other differentials were chronic hypersensitivity pneumonitis, which is a close differential of the same. SARS-CoV-19 was also kept in one of the differentials, and sarcoidosis and tuberculosis were kept lower down. This is the hospital course in which initially the patient did require oxygen at 4 liters per minute. We had an initial report COVID RT-PCR negative on the first day, but we started on antibiotics and steroids nevertheless. By day 7, we had another negative RT-PCR COVID report, and 2D echo had ruled out any chances of heart failure. By this time, the patient had received 5 to 6 days of dexamethasone. His oxygen requirement had decreased, but he had still fever, dyspnea, and cough. So at this point, the steroids were stopped, a BAL was done, and the patient had BAL positive for Klebsiella pneumonia, which was sensitive to levofloxacin. At this point, patient was having persistent fever spikes and oxygen requirement at 2 liters per minute. After the starting of culture-directed antibiotics, the patient had resolution in his febrile illness. He became afebrile with the decreasing oxygen requirement. And by day 20, he had become afebrile with no oxygen requirement, but his dyspnea, cough was still persistent. As our first differential kept was interstitial lung disease, we had started workup on the same lines and sent ANA and ACE levels. ANA came out to be strongly positive with 1:640 N titer in a speckled pattern, whereas all the workup for tuberculosis, including AFB, CB-NAT, fungal culture, had come out to be negative, no malignant cytology, no eosinophilia, and ACE levels had also come out to be within normal range. So by day 25, we repeated an HRCT to see whether there was resolution in findings after the resolution of fever of the patient, and it was confirmed that the patient had an ILD pattern overlapping with NSIP and organizing pneumonia with some mediastinal lymphadenopathy. So by day 30, we had a diagnosis of ILD with connective tissue disorder that was made, keeping in mind the positive serology and the clinical presentation of the patient, and the patient was planned for immunosuppressive therapy. By this time, we were ruling out any chances of active infection, so repeat cultures, repeat procalcitonin were sent and all came out to be negative. By day 36, the patient had received immunosuppressive therapy, 2 days following which his dyspnea had improved. He was discharged, continuing on 1 mg per kg per day oral prednisolone. He visited to us the first follow-up on 27/8/2022, 1 month later, wherein he showed progressively increasing total distance in a 6-minute walking test. He had good improvement in his clinical symptoms and signs, but he was still unable to perform his pulmonary function test. At this occasion, he received his second dose of injection cyclophosphamide. This is a summary of his timeline in hospital course. When the first week, he was treated as COVID-19, ruled out heart failure, but worked up actively for alternative differential diagnosis. On the second week, he was positive for Klebsiella, wherein the steroids were stopped. He was started on culture-directed antibiotics. By the third week, we had provisionally diagnosed him as having CTD with ILD. By the fourth week, we ruled out any chances of active infection before immunosuppressive therapy. And by the fifth week, he received immunosuppressive therapy. So while working up for the ILD, we by the third to fourth week had reached at the point where it could be an ILD with some systemic disease, but we could not point out particularly to what connective tissue disorder it could be. The reason was that clinically it was an ILD presentation, radiologically it was NSIP plus organizing pneumonia pattern. Serology showed ANA 1:640 and ENA positive for anti-DS DNA, anti-Smith and anti-Jo1. But the clinical features were not pinpointing to a particular connective tissue disorder with the absence of rash, photosensitivity, Raynaud's, proximal weakness or any Sitka symptoms, although some polyarthralgia and fissuring was noted in the patient. So in the clinical domain there was fissuring that might have been indicative. In the serological domain we had an ANA positive with a speckled pattern, and in the morphological domain we had an NSIP with organizing pneumonia overlap. At this point, we took the help of our pulmonology and rheumatology teams, and with some review of literature, a final diagnosis of interstitial pneumonia with autoimmune features, ILD, NSIP plus organizing pneumonia pattern was formulated along with hypothyroidism. For further discussion on this new entity, I would like to call my senior resident, sir.
So good afternoon, good morning all the respected seniors once again. So we would be discussing about this new entity known as idiopathic pneumonia with interstitial pneumonia with autoimmune features. So this is a relatively new term for us. For me particularly, it was a very new term which we came while dealing with this patient. So as more and more research is going on in the field of ILDs, it was found that a significant proportion of patients with ILD and with some autoimmune features, they do not particularly fit into any particular connective tissue disorder. So in 2015, the European Respiratory Society along with the American Thoracic Society, they came up with a new term, that is interstitial pneumonia with autoimmune features, to basically group all such patients who had ILD, who had some autoimmune features but were not fitting into any particular connective tissue disorder. And with more and more research, it was found that this proportion was significant. Around 7 to 34% of all patients with ILDs can fit into such a category. So the pathophysiology of this entity is found to have an overlap with various other ILDs. For example, patients with connective tissue disorder ILD and patients with fibrotic ILDs. So it has been found that their pathogenesis basically remains unclear, but they share some overlap with each other. So the pathophysiology exactly depends upon how the patient presents, and if it is a fibrotic spectrum, then there is basically fibrosis, and if there is connective tissue disorders spectrum, then there is basically inflammation. So in order to classify and categorize such patients, they proposed a criteria in 2015 which says that the patient should fulfill all the above three criteria. That is, the patient should have a radiological or histopathological evidence of interstitial pneumonia, number one. Number two, there should be complete clinical evaluation excluding other etiologies. Basically, it is a diagnosis of exclusion. And third, patient should not fit into any particular defined connective tissue disorder. So in order to meet this criteria for IPAF, the patient should fulfill all the above three requirements. In addition, he should have one feature from at least two of the following domains. So there are three domains. One is the clinical domain, that is the clinical features which the patient presents. Second is the serological domain, which is the blood investigation, that is the antibodies. And third is the morphological domain, which is either by biopsy or by imaging. So these are the three domains which we have. So in the clinical domain, there are multiple clinical features, the most common being the Raynaud's phenomena. And apart from there is digital tip fissuring, ulceration. However, in our patient, we had a history of polyarthralgia and a history of rash. However, we were not able to categorize it. Second important is the serological domain. In serological domain, we have a list of antibodies, but in our patient, we had a significantly high positive titer for ANA. Apart from that, he had anti-DS DNA, anti-Smith and anti-Jo1. In morphological domain, we either go by biopsy or by radiological, that is the imaging. So the most common clinical features in such patient, it was found that they usually present with Raynaud's phenomena. However, it was not there in our patient, and followed by mechanics hands or polyarthralgias. And it has been found that 90% of such patients usually have one of the following serological criteria which is positive, and that was same in our patient, that he had a high significant titer for ANA. So this is just a representative image of showing the mechanics hands, and the second picture is that of the Gorton's signs. So the management of such patients basically depends upon how these patients present. So just for a scenario, we have one patient of IPAF who has presented to us with a picture of NSIP pattern. So such patients which usually present with benefit with immunosuppressive therapy. Similarly, we have another scenario in which a patient with IPAF who is presenting to us with a UIP pattern. Such patients may not benefit from immunosuppressive therapy. So basically, the management of such patients, there are no definitive studies to tell us the exact management of such patients, but these management strategies have been extrapolated from other connective tissue disorder related ILDs. So patients who have features of connective tissue disorders and the basic physiology is that of inflammation, they benefit with corticosteroids and immunosuppressive therapy. However, patients who have features suggestive of fibrotic ILDs may not benefit from corticosteroids and immunosuppressive therapy. So this is just a slide summarizing the same, that patients who fit in the spectrum of connective tissue disorder related ILDs, their basic pathophysiology is that of inflammation. So they do not benefit, they benefit from immunosuppressive therapy and corticosteroids, whereas the patients who present in the spectrum of fibrotic ILD may not benefit from immunosuppressive therapy. So the basic take-home message is that in this era of COVID, post-COVID era, all cough may not be COVID. So patients who present in the emergency department, we need to work up them, we need to review the history and rule out other possible diagnosis, because the management in the long run differs. And some patients who basically have inflammatory pathology may benefit from immunosuppressive therapy. For example, in our patient, while he was in the course of our hospital stay, he was oxygen requiring for a long time. But as soon as we started him on immunosuppressive therapy, he became fine on room air, and it was very nice to see him when he came back walking with a very smiling face, and he was not oxygen dependent. So basically, he benefited from the immunosuppressive therapy. Thank you.